Welcome to the second Women in NAMA event. This is episode 2. Very excited to introduce this particular episode. I'm Nida Al-Muqaddam. I'm the president-elect for NAMA, and WIN is kind of something I care deeply about because I feel like as women, we have a lot of issues we definitely need to discuss. Today's episode is called I Just Don't Feel Like Myself, Common, Vague, and Bothersome Symptoms of Hormonal Transitions, is going to be presented to us by our speaker, Dr. Karen Horst. She is somebody with a very unique expertise in reproductive psychiatry. She is the medical director for the Women's Place, the Menopause Center, and she has a joint appointment with Baylor Psychiatry and Texas Children's Hospital. She is the medical director for the Perinatal Psychiatry Access Network. It is my great pleasure to have her present today. Her presentation will be moderated by Dr. Hind Musa, professor and vice chair in obstetrics and gynecology at the University of Cincinnati, and the Women's Health Informatics officers at Kettering Health. We were supposed to have another moderator, Dr. Dana Al-Khalid, from Northwestern Feinberg School of Medicine, but Dr. Khalid has a laryngitis today and cannot be moderating. We thank her for her presence anyway. She is here lurking in the background. So just a couple of reminders. Please keep yourself muted until it's time for Q&As, and you can then unmute yourself. And we're going to start with the presentation followed by the discussion.
Iran?
Thank you.
Okay, I'm going to share my slides. And good evening, everyone. So my maiden name is Homsi. So I'm half Syrian, but I'm also passionate about menopause and in general, the effect of hormones on women's cognitive and mental health. So I've been a reproductive psychiatrist for over 20 years. I actually went to medical school to be an OB-GYN. I did 2 years and some months of a residency in OB-GYN. And then I took some time off, had my second daughter, and then switched to psychiatry, wanting to be a reproductive psychiatrist. You can all see my slides now, is that right?
That's
Yes,
correct.
Karen. Thank you. We see
Okay,
them.
great. Okay, so we're going to start out just orienting everyone as to stages of ovarian aging or stages of a woman's life in terms of sex hormones and in particular the menopause transition. So this is the gold standard for understanding reproductive staging for a woman. It is the product of multiple longitudinal naturalistic studies done over in the 20th century, basically, in a number of countries, but particularly in America. And the first paper was called the STRAW. I forget, well, STRAW is Stages of Reproductive Aging Workshop. And it was published in 2001, I believe. And then the committee came back together 10 years later, and they refined the understanding of aging around menopause in particular. So let's take a look here. From left to right, we're looking at age chronology. It starts, the whole thing starts with menarche and then ends with end of life. Reproductive age is considered early, peak, or late. Variation of cycles is variable, and time is variable. So women's ovarian aging is affected by things such as genetics and whether you smoke or not, whether you work in where your circadian rhythm is shifted. So people who don't, who have shift work or who basically, yeah, we know it from shift workers. That can increase ovarian aging. being a twin, it actually is associated with earlier ovarian aging. There are a number of things. But anyway, so duration of reproductive age, which is when the ovaries are cycling and ovulating, um, is considered this period. And then you can see even in late reproductive stage, you start to see subtle changes in flow and length of a period. And we'll talk about what is sort of typical age for women here. And then there's some supportive criteria that um, aren't great. We don't have wonderful biomarkers for ovarian aging. The most sensitive one is the anti-Mullerian hormone here. And it is commonly drawn for women struggling with fertility issues, not for women who are wondering whether they are in perimenopause. Um, what is commonly drawn for women who are trying to figure out where they are in terms of menopause is FSH. And there are now direct to market products that are being sold to women where they can pee on a stick and get a read as to their level of FSH. And FSH is follicular stimulating hormone. It's produced by the brain, and I think of it as it's the brain yelling at the ovaries to do something. So here we have antral follicle count. That's the number of follicles in the ovary, and you see even in sort of late reproductive stage, you're going to start to see low antral follicle count. And let's see, as far as symptoms, the big one is vasomotor symptoms. And I'm going to now switch over. So we have menopausal transition that is broken into early and late. And then it ends with the final menstrual period. Perimenopause is more the lived experience for a woman, and it goes from the beginning of the menopause transition to when she knows she is now postmenopausal because she has had her last menstrual period a year before we call it she's in postmenopause. So postmenopause is, well, I'm getting a little confused here, but early postmenopause includes the year after the final menstrual period, but in real life, we don't know what that is until we've had the year without a period. So, and that's when we go from perimenopause to postmenopause. I have a better slide that's going to talk about more symptoms. So I just wanted to introduce you to the kind of gold standard. I want to draw your attention to a couple of other things. As you can see, AMH here is low, 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 and then not very low until quite into postmenopause. And the FSH is low, then variable. So again, it's hard to really pinpoint when a woman is in menopause. But once you're getting to greater than 25, so that's the voice is louder from the brain to the ovaries, that's when you can get a signal that a woman is in the menopause transition. The problem being a woman may have been in menopause transition for 3 years before her FSH is changing. So in terms of being able to tell a woman, yeah, you're in the beginning of perimenopause, we don't have great biomarkers. Any questions with this slide? Okay, I'll keep going. So we wanted to not, I'm a menopause specialist, but I'm also a reproductive psychiatrist. I work with women with PMDD, with perinatal mood changes, so during pregnancy and the postpartum period, We all know about the risk of postpartum mood changes like depression, anxiety, and even postpartum psychosis. Um, but I'm focusing today primarily on the perimenopausal time period. Um, but this is an interesting slide in terms of noting that women have a higher risk of depression than men, and in particular during our reproductive years and our perimenopausal years. The risk of depression is high. It's highest in the perimenopause. And what you can see down on the row down below is you see the cyclic ovarian hormone changes that are typical of a woman who's menstruating. And then when you get to perimenopause, you get chaos. So you can have hyperphysiologic ovarian levels due to something called loop episodes or loop events, which are late. Um, Sorry, I always spacing on do you know what a loop event is, Hind? I'm just forgetting it.
I'm a fan.
Yeah, you're
I
MFM.
actually do
I
not,
have
but yeah.
it's something ovarian out of phase. Um,
Okay.
it's an out of phase event. So luteal out of phase event. So what that means is that basically due to the ovaries not being able to
Yeah.
ovulate, um, the brain is yelling at the ovaries. The ovaries respond by sometimes double ovulating and producing two follicles. And as a result, you can get hyperphysiologic estrogen levels. When I was in perimenopause, my doctor actually drew my labs, and I had pregnancy level estrogen, which was very validating for me to hear because it was like, oh, of course, that makes sense. So anyway, chaos in early perimenopause in particular, in terms of highs and lows. And the lows of progesterone in particular are associated with depressive episodes in women in perimenopause. And then you can see postmenopause, things get quiescent if a woman, well, either way, even if you go on hormone therapy, things are stable. And you see that the rate of depression goes down significantly and stabilizes somewhat near our male counterparts. This is my adaptation of the straw criteria using the average age of final menstrual period in women in the US. It varies from country to country. And as you can imagine, genetics and stress are both impacting when a woman has her final menstrual period or her ovarian aging. So in America, right now we have average age 51. That means that a woman is in post-menopause at 51 on average, but she knows about it at 52, age 52. But early perimenopause can start in one's early 40s. Just on average. And how I got to this is we know that the average period of time, that a woman is in early menopause transition can be anywhere from 4 to 9 years. So if you extrapolate that from our average age of final menstrual period, you get symptoms can normally begin 10 years before a woman has her final menstrual period. And you may or may not have irregular periods. What you will likely have are these loop events. You'll also have low luteal phase progesterone, and you may have high sex hormone binding globulin. And sex hormone binding globulin is a modulator of sex hormones, but it's indiscriminate. So it binds estrogen, progesterone, and testosterone. So for me, in early menopause transition, I had very high sex hormone binding globulin. I had very high estrogen. I had very low progesterone and testosterone. So that's going to create a certain symptom profile, you can imagine. And so sex hormone binding globulin is an important thing to check if you are going to be checking hormones for women in the menopausal transition. What we know is some of the earliest symptoms of the menopause transition are mood, cognition, and sleep changes. And what women will note is that they are more depressed, they're more moody, kind of like premenstrual symptoms. They're more irritable. They're in psychological distress. They don't handle complexity, don't flow as well in their life, and it's causing a problem in their relationships or at work. For cognitive deficits, I want to give a shout out to us. Women have superior verbal memory than men at all stages of our life. But we take a huge hit when we go through menopause and sort of we're here, men are here. Men slowly go down, sort of gradually in each decade. Women, we stay pretty steady, superior in our verbal memory. So that means tell me 3 things to remember, and in 5 minutes come back and ask me for them. I'm going to remember them better than my husband. For women, we're pretty steady during when we have our ovarian hormones in our body. And then when we go through menopause, we have a sharp drop in our verbal memory, and women notice that. That's the most classic and enduring cognitive change that's found in all the studies. Other findings are short-term memory loss and difficulty learning new things. For insomnia, it can be early insomnia, meaning difficulty falling asleep. It can be middle insomnia, and that's sort of pathognomonic for the menopause transition is you wake up at 2 to 4 a.m. Maybe you're anxious, maybe you're not, but either way, you just feel awake. And again, it can happen really early in the menopause transition. Meanwhile, women typically don't have vasomotor symptoms at this stage, so no hot flashes or night sweats. And then we're going to talk about these two in a minute, but look at genitourinary. Low libido can show up here for that reason that the sex hormone binding globulin may be binding all the testosterone, and therefore a woman is functionally low in testosterone. So then let's look at the late menopause transition. That's typically just the few years right before the final menstrual period. Periods can start to skip at this time. So a woman will have a cycle and then have another cycle 2 months later. And so that's a frustrating period for my patients because they're like, I think I'm postmenopausal, and then they'll have a bleed. And it's like, okay, we got to start the clock over. But what's happening is she's not ovulating regularly. That's why we're not having periods at all. Estrogen is lower, therefore the lining of the uterus is lower. And again, we have the low progesterone. A lot of women in the menopause transition can also have heavy irregular bleeding or abnormal uterine bleeding. So menorrhagia, that kind of thing. That is also pretty common in the menopause transition. And then here we're going to still see all the mood and cognitive changes and insomnia, but you can start to see vasomotor symptoms in the late menopause transition. And you also have doubling of rate of fat gain, especially in the abdominal region. And you have loss of lean body mass. Some of the studies that are longitudinal of following women in the menopause transition show that there is weight gain, but some of the big studies like the SWAN did not. And so women may or may not have actual numerical weight gain, but they will still tell you I'm gaining weight in my abdomen, and I've never had this problem before. And it is not just cosmetic. Having abdominal weight gain and acquisition of fat in the abdominal region also suggests pericardial fat accumulation, and that is a risk factor for heart attack. And then genitourinary, if you have lower estrogen, you're going to start to see classic signs of low estrogen in the vagina, vaginal dryness, and therefore some dyspareunia due to thinning of the skin and decreased lubrication. And just a note, the vagina loves estrogen, and so they're one of the most effective treatment for a woman with severe vaginal dryness is local estrogen. Going on systemic estrogen also will solve that problem, but for women who can't take systemic hormones, using vaginal estrogen is very effective. There are other things that can be used as well. And then we have our final menstrual period. In that first year, early postmenopause stage 1A, we don't know we're in postmenopause yet. It's on average at age 52 in women, of course, no periods, and you're going to see variable to low estradiol. There are actually 4 different patterns of women going through menopause. Interestingly, and it's about a quarter, with some women having drops in estrogen early in the menopause transition, and some women having it quite late. You're going to have low progesterone because you're not ovulating. You're going to have those mood changes, although some studies find that once a woman is postmenopausal, depression is less likely. Other studies have not found that. And I've actually had a patient, at least one patient, whose doctor basically told her, you can't have menopausal depression in postmenopause. So you're depressed for another reason. It's not your hormones. And that's not true. Cognitive deficits persist, insomnia persists in this period. Early postmenopause is the most likely time a woman's going to have vasomotor symptoms. But studies have now shown that women can have vasomotor symptoms for over 10 years. So most likely here in this year, but not limited to this year. You continue to have this visceral, abdominal, and pericardial fat accumulation and the urogenital symptoms if you're not using hormones. Then we have, they got really nerdy here, and they broke postmenopause, early postmenopause, into 3 different stages. I think that practically for me in my own practice and explaining to women what to expect and kind of where they are, what this means is they can still be experiencing changes. This is still a dynamic time, even though they are postmenopausal. Women around age 60 on average is when things really settle down and that risk of depression goes down. What are common symptoms of the menopausal transition? So first I want to say there is no menopausal syndrome. So women can show up with all sorts of different complaints, but the most common are vasomotor symptoms, hot flashes, night sweats at 80%. But basically, as you'll see, for the ones where I have percentages, it's around 50% of women will have insomnia, depression and anxiety, cognitive changes 60%. Cardiac palpitations is one that is very common. I have had so many patients. It's fun to ask now. Every perimenopausal woman, I'll ask, do you have strange sensations in your chest? And 42 to 54% on average will say, yes, I do. And they often get referred to a cardiologist and they get a Holter monitor, or they at least get an evaluation beyond an EKG, and nothing comes of it. I don't think we know why people have that sensation. At least I don't know why. One thing I want to point out is vertigo. In my clinical experience, I have a ton of patients who have new onset vertigo. And this is likely having to do with inner ear changes. So clearly it's an inner ear phenomenon. But I've read, there are two papers that talk about it at this point, one in ENT and one in a neuro art journal. That are, so people are, clinicians and researchers are starting to talk about vertigo, but I can say clinically, I've had a lot of patients complain of new onset dizziness, nausea, vomiting, sort of Meniere's-like symptoms. I'm not even kind of going to go, I can say skin mucosal and hair changes are very common and very bothersome. And of course, something that women talk about. The under eye area is apparently very sensitive to estrogen levels. And so at one of the Menopause Society meetings, a dermatologist suggested using estrogen cream under the eye as an under eye treatment for wrinkles. I haven't gotten my I haven't done that, but after hearing that, I wanted to, but I never got around to it. Hair loss, and also hair loss can come in many different forms, including scarring alopecia, some male pattern balding, a lot of things women can present with during the menopause transition regarding hair. Of course, unwanted hair around the chin and lip is a very common symptom or sign. And then coming down here, we have weight and metabolic changes, weight gain, increased visceral adiposity, increased waist circumference. You're also going to have basically metabolic syndrome kinds of things. So HDL either changes and decreases, or there's some papers that say it's less effective at protecting, at being cardioprotective in the postmenopausal period. And elevations of LDL and triglycerides. See, then going to sexual function, this is an area that doctors don't ask often enough about, and and don't get enough training in how to talk to our patients about sexual function and changes. But this period of time statistically is a time of lowest sexual or highest complaints of sexual dysfunction during the menopause transition. And understandably, there also can be a lot of urogenital symptoms having to do with decreased estrogen and progesterone. And then musculoskeletal symptoms are also quite common. You have the sarcopenia, loss of lean muscle mass. But a lot of patients will complain of joint pain, 48 to 72%. So I've had patients talk about, it's painful when I get out of bed and I put my feet on the floor, and I have to be really careful when I start to walk to the bathroom in the morning. This is new, what's going on, that kind of thing. Mood and cognitive symptoms are, according to, this is a questionnaire, a survey sent out to women median age 48, the most common bothersome symptoms for women in the menopause transition have to do with brain fog, and just what volatile mood, fatigue, body pain that's new, of course, vasomotor symptoms, but also insomnia, and then anxiety and vigilance. There's a beautiful paper that I have quoted here where the patient experience is saying, I don't feel like myself. And that's a commonality to also that can be seen also postpartum and premenstrually. but it's particularly a common complaint in our menopause transition patients. And the biggest kind of disenfranchisement is that our doctors don't know about what's going on for them, and they tend to say it's psychiatric. It's a psychiatric problem. If if you're still having periods and you're in your early 40s, can't be menopause. And it must be that you are stressed, depressed. Go see Dr. Mukadam. So, kind of rounding out, how do we help our patients? How do we help ourselves? There are many treatments that have been looked at. None of this is well enough studied. And there's a lot of fear and disinformation about hormone therapy in particular. But I want to say, basically, if you all remember the WHI, or the Women's Health Initiative study, it was concluded, it was a huge study looking at use of hormones as one arm of a big study trying to help women age more healthily. And it had 40 different sites, a ton of investigators, very expensive study, NIH funded. And in the US, it started recruiting in the 90s, and it had a hormone therapy, placebo-controlled arm. And the hormones were a conjugated equine estrogen and medroxyprogesterone acetate. So very specific, an oral horse urine derived estrogen combination, and then, which is fine, but it's just specific. It's not what we use primarily now. And then medroxyprogesterone acetate, or MPA, which has been shown in vitro to cause to be mitogenic for breast cells. But what happened is, in the combined estrogen and progesterone arm of the study, they concluded the study in 2002 doing something that wasn't normal at all. They did a press release and a press, they went on the news, basically, the head researchers. And they didn't consult with the entire investigator group. There was a safety committee within the WHI that made the decision unilaterally to conclude the study. And it was controversial because their reasoning wasn't that good. In particular, if you look at women of age 50 to 59 who were given hormone therapy, they weren't having the negative outcomes that the women who were older in the study had. The average age of women in the WHI was 63 years old, so late postmenopausal. And it was a study powered to see if hormone therapy was effective for prevention of late life illness, cardiovascular disease, osteoporosis, that kind of thing. But the people in the study who were in the menopause transition or early postmenopause who received hormone therapy, they actually didn't have the negative outcomes that the older groups did. And yet the people who were in the safety committee decided to call it and announce that using hormone therapy was associated with a 26% increased risk of breast cancer, among other things. And that's what caused the whole pall on the use of hormones in women in the menopause transition and postmenopausal, and with our association with breast cancer. And it turns out, it looks like it was actually the medroxyprogesterone acetate, not the estrogen, that's associated with the breast cancer risk. And that the in women who were 50 to 59, the increased incidence was still a rare increased. I think it's 8 in 10,000 women who were receiving combined hormone therapy developed a breast cancer. But meanwhile, I don't have the slide, but I should have it. I'll pull it up when we're talking, perhaps. But the WHI found that all-cause mortality was reduced significantly in women who received hormone therapy compared to placebo. And yet we all still associate hormone therapy with a risk of breast cancer, and that the risks outweigh the benefits. So anyway, talking about treatment, hormone therapy is effective for these 5 main categories of symptoms. It's the most effective treatment for vasomotor symptoms. And the FDA recognizes that for severe vasomotor symptoms, hormone therapy should be considered. For depression, anxiety, and insomnia, hormone therapy alone is effective. So essentially, it's an antidepressant. In fact, for the mental health people, if you know what an MAO inhibitor is, it's an older antidepressant. It blocks the metabolism of serotonin, norepinephrine, and dopamine. Estrogen acts as an MAOI. And so it's quite effective for depression, anxiety, and insomnia. Cognition, we can't figure it out. Where we are right now is we don't believe it's negative in any way, which is contra what was found in the WHI. It's not harmful to go on hormone therapy, but we don't know that it's protective. Weirdly, we do know that women who have a bilateral salpingo-oophorectomy or BSO earlier than age 52, if they go on hormone therapy, they have a lower incidence of dementia. So it should be pretty clear in the OB-GYN community that if you have a patient who has an oophorectomy in her 30s or 40s, she really should be on hormone therapy to protect bone, cardiovascular system, and brain. The interesting thing, the only other intervention here that hits all the points is exercise. And exercise is really, as you all probably know, I mean, it's very good for our health, our mental health, and our physical health to move regularly. And in the menopause literature, it's been shown to be effective for, to improve cognition. I think of it as it's helping pump out all the trash in my brain when I exercise. It's literally increasing blood flow, and it's helping with the lymph system in the brain to get things out. And it also reduces stress to exercise. So not a surprise, it's helpful for cognition. Exercising also increases something called brain-derived neurotrophic factor, which is a growth hormone for brain cells and also promotes neurogenesis. So that's another reason why we all should move. It's also BDNF higher levels of BDNF are associated with less depression, and low BDNF is associated with more depression. So exercise, really good, and I love working with women in this age range because they often have the bandwidth and the funds, the time to actually devote some care for themselves and to do things like get an exercise routine established for themselves. And it's very gratifying for them, for their doctors, everybody. So anyway, exercise is great. Interestingly, when the WHI results came out in 2002, and then starting in 2002, their antidepressant prescriptions skyrocketed. So hormone therapy plummeted, and SSRI and SNRI use skyrocketed, and it pretty much mirrored each other. And it's not just sort of a, I don't know, Dr. Mukadam, you can talk about your feelings about this, but you know, our antidepressants, the SSRIs and SNRIs, are actually very good at controlling vasomotor symptoms.
Exactly.
Yeah. So, and they're very good for, and they're very good for depression and anxiety related to hormone fluctuation. For insomnia, it's mixed. Some people have disruption of their sleep with use of SSRIs, SNRIs, and some women sleep better if they go on an antidepressant. So that's mixed. Um, um, we don't have there regarding cognition. I kind of wanted to put a little plus here, because when people are euthymic, they tend to have lower rates of later dementia. So I think of the brain as healthier. You know, we know that the brain is plumper if a person is not depressed, and on treatment for that, if that's what gets them out of their depression. And so I kind of want to put a plus here for cognition, but in the menopause literature, we don't have it. So anyway, psychotherapy is also very effective for helping women kind of understand, accept, and figure out how to have skills to work with their changing body, and the symptoms that might be showing up. So there's CBT for vasomotor symptoms. There's CBT for insomnia. There's CBT for depression and anxiety, and psychotherapy can be very helpful in this period. Of course, this period in a person's life is also a time when you're sort of going through a midlife crisis of sorts. You're reassessing. You're realizing your life is finite. You're no longer looking for goals for the future. You've hopefully attained a few of your goals, and you're starting to reflect on how you're living your life and whether you're happy with how you're living your life. It's also a time when people often are raising children and also caring for elderly parents. It can be a time of increased responsibility at work, which can be gratifying but also stressful. So lots of reasons to do psychotherapy in the menopause transition. There are new medicines called neurokinin 3 receptor antagonists that are effective for vasomotor symptoms, not as effective as hormone therapy or even antidepressants, but effective and a non-hormonal treatment. So the one that's out on the market right now is called Veoza, or generic is fezolinetant. The problem I've seen is that it's very expensive and insurance coverage is spotty. But it's an improvement, and there's one in, I think it's phase 2 or 3 studies right now that's an NK1 and 3 receptor antagonist. It's called elinzatant, and elinzanetant. Oh God, I didn't practice this. Anyway, it's also being looked at for insomnia. And then gabapentinoids have a place in the menopausal transition for treating vasomotor symptoms, anxiety, and insomnia. Classically, the studies show that you need to get to 900 milligrams a day of gabapentin, which is quite a lot and may be prohibitive for patients. They may feel too slowed down. But I can say in my practice, I've found women respond well to 100, 200, 300 milligrams of gabapentin at night. This is for a woman specifically who can't go on hormone therapy. If they have a personal history of breast cancer, for example, or if they are just not, they're too fearful of hormone therapy. And then there have been studies looking at the use of psychostimulants, so treatment for ADHD. medicines that increase the activity of norepinephrine and dopamine, such as Adderall, amphetamine salts, Ritalin, methylphenidate, and Vyvanse. There's also a non-stimulant treatment for ADHD that's been studied in menopausal women for cognitive change called atomoxetine, brand name Strattera, that has in a small study was shown to be effective. The one thing you want to think about for these women is we're not going to call it ADHD. We're going to call it cognitive change with menopause. And we're also going to think about taking them like it's temporary. It's for the period of time when you're in early postmenopause. And you should stabilize at some point. And there are studies looking at the brain and what happens later in the postmenopausal period where the brain stabilizes and cognition stabilizes or even rebounds a little bit. And finally, actually we have a few more. Speaking of sexual function, so testosterone really is well associated with desire and ability to have an orgasm, and particularly desire. In women, our ovaries produce testosterone, and the decline in testosterone isn't abrupt during the menopausal transition. It is happening all during our reproductive age period. And it basically kind of goes down gradually, as you can see. The postmenopausal ovary is an androgen secreting organ. And the capacity for the ovaries to produce follicles is independent of its production of testosterone. So what that means is that for women who go through surgical menopause, they are abruptly going to have a sharp decrease in their testosterone levels, which they're usually going to notice. And I think that's my, oh, no, one more slide. Okay. This is a study done by someone named Neil Epperson. She's a reproductive psychiatrist currently at the University of Colorado, Anschutz. And she looked at the association between women with a history of adverse childhood events and recurrence of depression or new onset depression during the menopause transition. And what she found is that the number of ACEs correlated with higher rates of depression. And so looking at the x-axis is number of ACEs. And this is complicated, not the best, not my favorite graph. She's comparing women with pre-pubertal adverse childhood events and post-pubertal adverse childhood events. And what she found is that women with a history of post-pubertal adverse childhood events, in particular, had a higher risk for, higher risk for depression. And I know that from the paper. I just pulled this slide. So let me see if I can. So incident menopause, major depressive disorder is the y-axis, and so
I
higher.
can jump in since you put that here for me.
Please do, please do.
I have to thank Dr. Horst because she indulged my every question and request. So basically, we're telling the story of perimenopause and we're asking who is at risk for perimenopause and who's at risk for all these problems. And it looks like women with a history of trauma, especially earlier trauma in life, are at much higher risk of depression once they hit menopause or once they start hitting that perimenopause period. And there is even a breakdown by age. So the earlier the trauma, the worse the symptoms are. So if you have it and you've already been pubertal and you're a little bit older, you probably can handle it a little better. that's the short and sweet on it.
We don't know why, but I can tell you clinically, I see it. Yeah. So that's it. I will stop sharing.
Thank you.
My pleasure. Happy to have a discussion. Oh, we're at time. Oh my gosh. What?
We do have another 10 minutes. Thank you so much, Karen. This is very informative and such an important topic that unfortunately we don't know much about, especially even for us women, you know, and it's very interesting. I wanted to comment on the vertigo and the, you know, aspect. It's funny, Dr. Haddad, Ghassan Haddad, was a fellow when I was doing my residency in Cincinnati. And then his thesis was looking at how in menopause, there's downregulation of estrogen receptor in the middle ear. So,
Oh, okay.
there is a link. I don't know if he published it or not, but he presented it like a long
Wow.
time ago. So that link has been described, but it's very interesting. And that's
Oh,
why
thank
with
you.
osteoporosis and then women being more prone for falling and
Yeah.
So I do have lots of questions, but if someone else from the participants will have any questions, if you want to please chime in, or if you want to put it in the chat box, we'll be happy to ask them. Heidi, I think, has her raised. Yeah.
Yeah, hi, thank you. That was a great talk, Dr. Horst. I enjoyed it. I have a question for you. What are the current recommendations for forms of estrogen, whether it's patch, whether it's oral, whether it's, you know, estradiol, I know I'm a pulmonologist intensivist, so this is
Oh,
way
okay.
out of my wheelhouse, but
Yeah.
you know, I've been in perimenopause forever now. So
Yeah.
I'm asking for a friend.
Okay, asking for a friend. I hear you. So the go-to, and there've been the favored for risk factors and like adverse events is transdermal estrogen, so a patch, or there's or you can do it many different ways. There's something called Evamist, which is a spray. So the ones I've seen most commonly are patch and Evamist. That's sort of from the academy. That's what we recommend. We do not recommend compounded estrogen from a compounding pharmacy because it's not quality controlled. And we've seen that there are variations in product quality. So what's recommended is transdermal estrogen. It's going to be estradiol or E2. And the dose range is anywhere from 0.025 milligrams per 24 hours up to over 0.1. What I've noticed, interestingly, being a psychiatrist, is that some women have a bump in anxiety when they go on estrogen. And so it's really important to start at that intro dose, sort of like I start an antidepressant. And it's a similar sort of risk for activation with starting estrogen as there is with starting an antidepressant. So that's the estrogen. The reason we like transdermal is that you don't have you bypass first pass metabolism and you don't activate the liver to produce high triglycerides and increase the risk of clots. So transdermal preferred over oral to reduce risk of clots and metabolic effects. But if some women don't absorb transdermally well enough and they end up getting transitioned to oral. And of course, some doctors start with oral.
And is that like a clinical decision or is that per checking levels? In terms of
it's checking levels.
Gotcha. Okay.
Yeah.
And what level do you expect to see in checking labs? And that's my last question.
That I don't know offhand. This is where I hand it off to my gynecologic colleagues. So I I don't know what number they're looking for. Yeah, I know for testosterone, but I don't know for estrogen. I'm sorry. Okay. And then for progesterone, we prefer P4 or the progesterone that's bioidentical with our progesterone instead of one of the synthetic progesterones. There are many generations of synthetic progesterones, and they come with varying side effects. Some have mineralocorticoid side effects, or they activate androgen receptors. And then others, the later generation, are actually anti-androgen and don't have that mineralocorticoid effect. So you don't have fluid retention, breast tenderness, as much breast tenderness. And then there are mood changes that can come with any progesterone. And we don't understand it well enough, but we do know that synthetic progesterone tends to have more mood change than P4, or the progesterone we use. Micronized progesterone is another word for it. Other nice things about progesterone. So progesterone gets metabolized in the body to allopregnanolone, which is actually a treatment. It is the one FDA-approved treatment for postpartum depression, and they're looking at it for perimenopausal depression. But allopregnanolone is like benzos. It has GABA A receptor agonism, and so it tends to help with sleep. Bottom line. So it's a great way to help a woman with the insomnia with perimenopause. And then there are other things. There are SERMs. If a woman has concern about breast cancer, one option is to use estrogen plus bazidoxifene, which is a selective estrogen receptor modulator. So there are a number of different ones that have lower risk of breast cancer, basically, but are protective for bone, for example. Finally, there is a new generation estrogen called estetrol that is E4, and it's produced by, it's the weirdest thing, it's produced by fetal liver. But it's more like a SERM. It has a lower risk of blood clot. It's oral, and it has a lower risk of blood clots and a lower risk of breast cancer.
Thank you so much.
My pleasure.
Very interesting. Do we have any other questions?
I have a comment.
You can comment, Nidal.
So one of the reasons for this lecture was that I've believed for the past 20 years that there's a conspiracy theory that so many women in our age group get placed on antidepressants, and that the WHI study was incredibly unfair because they picked women who had already been menopausal, so their bodies had already adjusted, and then they were giving them those hormones, which were not even thought through totally. And obviously, once your body has gone through the stress transition, it would have been hard. So I feel that this lecture has answered all these points, and thank you very much.
Oh, thank you. Thank you, Nidal. I share your conspiracy theory. I think somebody needs to do at least a podcast on what happened. And I can tell you, there are some very hot papers where some of the investigators are very angry at other investigators. And very angry at the United States Preventive Services Task Force, because they still follow the WHI and they don't recommend hormone therapy for prevention of osteoporosis, cardiovascular disease in women.
We have a
We have a
question.
question in the chat box. Is postmenopausal depression triggered by life events?
Haha.
By Lama.
Some people speculate that. I don't. I tend to think it could very well be biologic. Yeah. But I've had a patient be told by her doctor it can't be due to menopause if you're depressed and you're early postmenopause. And that's not true. It depends on the study you look at. The SWAN study showed that the incidence of depression went really normalized in the postpartum, but other studies didn't show that. The POAS and the Seattle Women's Study and other studies showed that the risk of depression is still high in early postmenopause. Yeah.
I wish we have more time. I have several questions and a comment, but I know that now women, you know, especially within our field, we see a lot of women who are having their kids later in life, and we have now women who are having their kids in their late 40s, 50s, naturally or via IVF. Some are postmenopausal as well. I don't know if there's any literature regarding that population of what's their status in regards to that transition, and then how do they do like later in their lives as well.
Yeah, a good question. So I can tell you, so our clinic sees women up to a year postpartum, and then we have to graduate them. And that's to keep the doors open to see new patients. But there's a special group of patients, and then I see menopausal patients, but there's a special category of patients I see who have a history of postpartum depression or peripartum depression, and they're in their early 40s and they have a child, or mid 40s or late 40s, they have their child, and then boom, they're in menopause. And I get to keep them.
Yeah,
So
that's so interesting, you know, because especially like looking at longitudinally, we're technically age 51 is middle age for women. It's not,
right.
you know, so I think it would be very interesting to look at maybe personalized treatments, genetics, looking at also other factors whereby like how medical management or psychotherapy or treatments would be individualized instead of like categorizing them into big categories. So
Yeah, and that's where we should go. So, for example, women who have a significant trauma history, childhood trauma history in particular, they're at higher risk for perimenopausal depression. So we need to identify them and